Okay, hey guys. So, again, like I said on Tuesday, we're going to talk about reproductive choices. Although, maybe it's not your most fun topic to talk about, we do need to talk about it. And I do think it's very important to talk about, especially at everyone's age. So, let's go through each of these things. And I do have my book in front of me so I can read you some statistics as we go along. So, if you want to pull up your book and have your book out, wait, you don't have your book. I told you not to get it, so never mind. I will read the stats off to you. They're also on the PowerPoint, which is on Blackboard. So, reproductive choices, lots of different things going on. So, we have the idea of conception, which is the very beginning. So, we're going to talk about the whole complete phase of all of this and what pretty much leads from sexual activity, which is a baby most of the time. So, conception, the creation of sperm, which is spermatogenesis. That's a very long word. That's the creation of sperm again. Ejaculation, like I said on Tuesday, contains over 500 million sperm, which is a lot if you think about it. Men typically produce sperm throughout their lifetime. It tends to fade whenever you get older, but not like women. Women have a set amount of eggs that they are born with versus men who can recreate sperm. So sperm must move through the vagina, uterus, and up to the fallopian tubes, where they will connect or not connect with the nucleus of an egg. So the egg is going to sit in the fallopian tubes where it's dropped from the ovaries. So the egg is dropped from the ovaries into the fallopian tubes after ovulation, and then if you have sex after ovulation, then, or unprotected sex, I should say, then sperm move through the vagina, through the uterus, to the fallopian tube, and either fuse with the egg or don't fuse with the egg. Like I said, each woman is born with a certain amount of eggs, and anywhere between 300 and 500 eggs is what we're born with in a lifetime. The egg drops to the fallopian tubes into the uterus, like I was saying. The unfertilized egg lives for about 24 to 36 hours and is dispelled during menstruation, like I was saying on Tuesday. So the egg is dropped, and then whenever the egg is not fertilized, it is dispelled with the uterine lining through menstruation. So sperm can live between 2 to 5 days, so if you have unprotected sex, keep that in mind, that sperm do keep in the body from 2 to 5 days, and you can still get pregnant that way. A fertilized egg is called a zygote, and then if the zygote turns into an embryo, the embryo then turns into a fetus. So I do want to talk about contraception. So let's talk about the different types of contraception, and we did talk about this on Tuesday. Your book gives a great table, and I'll post that online for you so that you can have it. It talks about sterilization, which we talked about on Tuesday. It gives you the implantable rod, IUD, shot injection, oral contraceptions, all of those things, which we will break down in just a minute. We'll also talk about the benefits and the risks of each of those things. They do have a lot of different benefits and risks that come with each of those. Before we get to contraceptions, I think it's very important to talk about birth control in America, because birth control is a very big part of America, and I do think it's important. So 62% of women between the ages of 15 to 44 are using some form of contraception. That doesn't mean oral contraception. That could mean a condom, that could mean a female condom, that could mean IUD, that could be an injection, it could be anything, any type of contraception. Non-Hispanic white women have the highest rates of contraception. Current contraception is used higher among women between the ages of 25 to 34. So that's between that young age where women are not looking to have kids most of the time. And then 35 to 44 are also using contraception more than the ages of 15 to 24. Now, I'm assuming that's because of the age range, and those kids don't really have control over contraception as much as an older adult would. So a 15-year-old is not going to be able to go to the doctor and say, I want oral contraception, or go to the store and buy condoms without their parents knowing, those sorts of things. So most of the time, ages between 15 and 24 are the most unprotected because they don't have the capability to take care of that themselves. And then the most commonly used contraception forms are birth control pills, female sterilization, condoms, and then the long active reversible contraceptives, which is things like NuvaRing, things that last for a longer period of time, IUDs. Each of those things are long active but reversible. And I also find it very interesting that there's a lot of different cultural perspectives when we talk about birth control, and I think we forget to acknowledge that our culture is very different from other cultures. So, in the United States, 62.7% of women who are married use contraception. So that's more than 50% of women who are saying that they're married are using some form of contraception to either not get pregnant or to not have any more children, that sort of thing. More than 100 million women worldwide, use combination of oral contraceptives and condoms. Ages 25 to 44, women in the United States, England, Germany, Italy, and Spain were most likely to rely on oral contraceptives and the male condom. So that's a very wide gap between multiple different countries using oral contraceptives and condoms. So that's a big research stat there. Japan has one of the lowest rates of birth rates in the world, and research shows that men are more responsible for sexual or contraception of some sort. They make the birth control decisions versus women making birth control decisions. In Kenya, the research shows that condoms are a sign of infertility among men whenever they are married. So if they suggest to use a condom, then women think that their spouses are cheating on them. And then Scandinavian countries, birth control is actually free and it's easily accessible, which is interesting. So lots of different things going on there in Scandinavia. Lots of different contraception choices, which we're going to break down. So again, we're going to break each one of these down. So barrier contraceptives are very different from oral contraceptives or hormonal contraceptives. So barrier contraceptives are going to be things like condoms, sponges, spermicides, each of those things. So a male condom is, hopefully everyone already knows this, but if you don't, it is typically a latex glove, quote unquote, that covers the penis during sex and catches semen once the man has ejaculated. So when you use a condom, you need to leave a little bit of space at the very top so that way it catches the semen at the top and doesn't fall out. A female condom typically is flexible sheath or pouch that is inserted into the vagina, and I have provided lots of information on the PowerPoint and photos of what a female condom is supposed to look like. Contraceptive sponge acts as a barrier by blocking the entrance to the uterus and absorbing the sperm and deactivated sperm. So it sits there and it's kind of like a protector and catches everything. Vaginal spermicides consist of chemicals that kill sperm and potentially pathogens. They are jellies, creams, foams, or filaments, and they hold spermicide to close the cervix. So they sit at the top of the cervix, and they have different types of jelly or foam in them, and they catch and deactivate all of the sperm that come that way. Okay, so let's really break each one of these down because I feel like it's important for you guys to understand each of these different options. So male condom. Guidelines for using a male condom. Check the expiration date. Condoms do go out of date. Contrary to everybody's belief, they do go out of date. So check the condoms. If you use an expirated condom, make sure that it's not broken. Make sure it's not flimsy. Make sure it's not yellow. When you are having sex, do not tear the packet with your teeth and do not cut it with scissors. So if you tear it with your teeth, you're more likely to puncture a hole in the condom, which is going to cause sperm to get out, which could cause pregnancy, STI, STD, that sort of thing. If the condom is yellow or sticky, don't use it. I would hope that you would understand that and not do that. Like I said, leave a little space at the top for the condom to catch semen. If you do use lube while you're having sex, make sure that the lube is water-based. So you don't want to be using oil-based while you're using a condom because that's going to deteriorate the condom and eventually it will tear. So make sure you're using water-based lube whenever you use lube with a condom. Also, after ejaculation, make sure you hold the condom to the penis so that way it doesn't slip off or fall off and you get semen inside of your partner or you get semen everywhere else. The condom is relatively effective if you're using it properly, which is 80 to 85% effectiveness. It is the second most used contraceptive to only the pill. And most men tend to not use condoms due to comfort issues. They say that it doesn't feel the same, doesn't feel natural. You can't feel pleasure that way. So that's a personal choice, I suppose you could say, but make sure that you're being careful and make sure you're using the right options and talk to your partner about it. Now, the female condom inserts, slowly you push it back through the small of your vagina. So what happens is the outer ring is in the opening of the vagina. Then the back half is in the inner ring sitting against the cervix. It can be placed into the vagina up to 8 hours before sex, so that's your preventative measure. It's not taking any time, it's not ruining the moment if you already have it in. Effectiveness is 75 to 82%, not as high as the male condom. Friction of the female condom may reduce clitoris stimulation, which can cause the woman not to have an orgasm. And then the book did say that proper use of the female condom is almost better than the male condom at preventing infections. So the female condom actually covers the entire vagina all the way back to the cervix, which causes less STIs and less STDs. Contraceptive sponges, the advantages and disadvantages of sponges, they're easy to use, they're easy to put in, can be inserted 24 hours before sex. They're effectively used if you use them properly. They don't have any effect on fertility, and they also aren't felt by your partner. So neither one of you can feel that they're there, so it's not a comfort issue. There are a lot of disadvantages to sponges, so you need to be aware of those before you use them. So they are difficult to remove. They have less effective rates in women who have already had children. They do not protect against HIV, STIs and STDs. They require advanced planning to place, so you can't leave them in there for an extended period of time like you could a female condom, and they should not be used during menstruation for obvious purposes. They also increase risk of toxic shock syndrome if left in there for more than 24 hours, so do not leave that sponge in there for a long period of time. That's going to cause a lot of problems. Then we have the vaginal spermicide. So spermicide, again, we're going to talk about this pretty in depth, is easy to use. It's effective with another contraception. So do not use spermicide by itself. Use something else. Do not use it by itself. It reduces the risk of vaginal infections, so that reduces the risk, and it also doesn't have fertility risk. When used alone, don't think it protects against STIs, STDs. Again, don't use it by itself. Frequent use can cause risk of HIV, so if you're using spermicides, quite often it can cause risk. Insertion interrupts sexual spontaneity, so you can't put it in long term, like 6 hours before. You have to do it right before you have sex. It may cause irritation as well, and some people have allergic reactions to jellies, foams, etc. Okay, so let's talk about the prescription barriers, because each of those things that we just talked about are non-prescription barriers. And there are different prescription barriers. So we have the diaphragm, which is a fitted and prescribed healthcare professional, almost like a little cup. It's a container for spermicide foam or jelly, and it's fitted specifically to your cervix. So each of these things are for the woman. So it remains in the vagina at least 6 hours after sex to ensure that all sperm are killed. And I've given you a depiction in the PowerPoint and a little image of what each of these things looks like, so you can get a good idea of what they represent and how they work. Cervical cap is about the same thing. It's fitted professionally by a healthcare professional. It's a cup. It's filled with spermicide. The cup is pressed into the cervix, the very back of the cervix. It's inserted up to 6 hours before sex, and it's not removed until 6 hours after sex. So you're going to find that each of these prescription barriers you cannot remove until at least 6 hours after sex to make sure that the barrier has caught all of the sperm. And then you also have the fem cap, which is a bowl, and it's inserted into the vagina. It pushes all the way back to the cervix and is placed, again, 6 hours after sex. And again, I've given you photos to make sure that you understand how each of those things work. Then we move to hormonal contraceptives, which is the oral contraceptives. So you have oral contraceptives, which is advantages. It slows down your hormones so that you don't ovulate. When you don't ovulate, then you can't get pregnant. So when you're taking oral contraceptives, you don't ovulate, you just have a menstruation. So therefore, you don't have an egg that drops for you to potentially get pregnant. Oral contraceptives also help prevent different types of cancer. They help prevent different types of diseases because you're restricting hormones. Combination oral contraceptives, they both block ovulation. So again, the ovulation is blocked. However, with the combination oral contraceptives, you're not getting the ovulation. The monophasic pills, they are constant dose of estrogen and progestin during menstrual cycles. And then your multiphasic pills they mimic the function of cycles through estrogen and progesterone at different times of the month. So it fluctuates your hormones that way. Then you have the progestin-only pills, which cause minimal ovulation. So you still ovulate maybe once every couple of months, but you're still at risk for getting pregnant because you're still ovulating. So you're not completely stopping ovulation, you're only minimally stopping ovulation. And then we have the patch, which you put the patch on for 3 weeks. It helps with hormones, and then the 4th week you take it off, and that's your menstruation week, which you can still get pregnant during menstruation. Apparently your book says that the patch is highly effective when used properly, so make sure you're using that properly. Some more hormonal contraceptives: NuvaRing, IUD, injections, and implants. So the NuvaRing is a plastic 2-inch ring which compresses a woman. It stays in place for 3 weeks, and then it's removed by yourself for the 4th week for menstruation. So you're putting in yourself and you're taking it out yourself. The IUD, a physician has to insert, so it's a small piece of molded plastic with a string attached to it, and is placed into the uterus through the cervix. So it prevents pregnancy by interfering with implantation of an egg. So it prevents implantation of an egg that way. Then you have your injections, which are progestin-only pills done through a shot. They last 3 months, so you don't have to worry about taking a pill each day for 3 months. You just go get your shot. It lasts for 3 months, then you go back after the 3 months and you have another shot. Or you don't have another shot, either way. Implementation, so it is a thin, flexible implant in the upper arm. So again, it's placed in your upper arm. It releases progestin and suppresses ovulation. So all of these hormonal contraceptives are giving you estrogen or progestin to keep you from ovulating, basically. So if you don't ovulate, you can't get pregnant. Okay, so controversial topic, unwanted pregnancy. So we're going to have to talk about abortion. And whether you want to talk about abortion or listen to me talk about abortion, you have to, and I do apologize. Keeping all politics aside, I'm giving you the facts of what we know and what your book says and what research says. So just keep that in mind. So unwanted pregnancy typically results in some form of abortion. So medical abortion is defined as a method of ending a pregnancy within 9 weeks of conception using hormonal medications that cause expulsion of the fertilized egg. So it's not a fetus, it's just a fertilized egg, and the medicine is making the egg pretty much dissolve and disintegrate and expel from the body. So some statistics for you guys about medical abortion. Rates have been declining since 2002. We're at an all-time low for abortion. Most take place in gestation, so less than 13 weeks are typically when abortions happen. More cramping and bleeding happen during medical abortions, and that's because you are expelling an egg. So it's basically making your body shed that lining just like a menstruation. So you're going to cramp more, you're going to bleed more versus a surgical abortion, because they're just removing the egg from your uterus versus you expelling it. Okay, so again, politics of abortion, we have to talk about it. We do. It's part of this. It's a part of reproductive choices. So background of abortion. Abortions were legal until the 1860s. In the late 1960s, some states changed their law so that you could have abortions. So that's the 1960s. In 1973, vote Roe versus Wade. Everyone's heard of Roe versus Wade. That's a big topic in today's society, even still. Roe versus Wade said that an abortion in the first trimester of the pregnancy is a decision between a woman and her physician. So that's not up to politics, is what they were saying. They were saying that the first trimester is basically at the discretion of the woman and her physician. Roe versus Wade continued, and they defined that abortion in the second trimester could be performed based on health risks. So health risks for the baby, health risks for the mom. That's again up to the mother and the physician at that point of the second trimester of health risks. And then abortion into the third trimester is solely based on the mother's health and what they have to do to help save the mother. So that is a healthcare decision only and not a personal decision. That is based upon the mother's health. Okay, so then we move from abortion talk, right? So the unwanted abortion talk to actually having a baby. And I find all of this very interesting, and I find it very exciting. Not because I want a baby, obviously, but I think it's a very interesting topic. So pregnancy, there are many different things that you have to consider when thinking about pregnancy. You have to think about preconception care, which goes with your risk assessment.